Well, hello everyone. This is Dr. Tushar Mehta. I'm an orthopedic surgeon and your faculty of orthopedics. Today, I'm going to discuss with all of you a very, very basic topic which has been there in our memories. I can just revive those memories for all of you. So, I hope you remember that when you were in MBBS, first year, anatomy, upper limb, BD Chaurasia, volume 1, what was the first topic that we all were discussing? Shoulder joint. Now, in shoulder joint, I hope you remember that you went with your textbook to a senior or to a friend and you said, which are the important topics that can come in this exam. And if somebody can give us a marking, then one of your seniors came and told you that, dude, read this topic. This will surely be in your exam. And what you did, you came back to your room, to your reading room, to your library, and you started remembering that topic. And I hope by looking at this, all those memories we have revised with all of you, all those memories are, I think, coming back again. So, by the way, we are talking about what? Can anybody tell me? We are talking about that very, very important topic here. That is what is called as rotator cuff. Now, what is rotator cuff? Please try to understand. Rotator cuff is a musculotendinous cuff which is surrounding the shoulder joint. Now, if you look at this image, this is a cross section of the shoulder where you can see a pear-shaped glenoid cavity. Head of the humerus has been taken out for easy understanding. That's why it's a cross section, which I said. So, what you are looking at right now, is technically a glenoid cavity, which is a pear-shaped cavity. Now, before I go further, I want to tell you something that whenever we have a joint that is packed in a polybag, and that polybag is what is called as capsule. So, what you have surrounding this joint is what is called as capsule. Now, this capsule, believe me, is blended with four tendons. This capsule is blended with four tendons. Now, when I say four tendons, what are those four tendons? So, one tendon is called as subscapularis, the other tendon is called as supraspinatus, the other one is called as infraspinatus, the other one is called as teres minor. Now, all these four tendons blend together to make something which is what is called as rotator cuff. So, it is technically blending of the capsule with these four tendons. So subscap, supraspinatus, infraspinatus, and teres minor. Now, when these four tendons they blend together, they make the structure called rotator cuff, which is definitely present superiorly, which is present anteriorly, which is present posteriorly, but that is deficient. I'm sure you all can make it out inferiorly. And that is why whenever an episode of shoulder dislocation happens, it is absolutely a fact that head of the humerus first dislocates inferiorly. But that is also a fact that after dislocating inferiorly, in majority of the cases, it goes anteriorly, and therefore in shoulder dislocation, which is the most common direction, anterior, even though dislocation of the head first occurs in inferior. Some of you who have just heard me, watched me, might be having a question that if rotator cuff is deficient inferiorly and if head of the humerus first dislocates inferiorly, then why the hell inferior dislocation is not the most common? Why is it anterior? See, I'll tell you again. We're orthopedic clinicians at the end of the day. For us, the final direction of shoulder dislocation is the final position of the head of the humerus with respect to glenoid when the patient comes to us. So I told you, I'll tell you again, that head of the humerus, because of the inferior deficiency of the rotator cuff, will first dislocate inferiorly, but in majority of the cases, which is around 90 to 95%, after dislocating inferiorly, it will go anteriorly. In 3 to 4% posteriorly, and believe me, it will stay inferiorly as well, but only in 1 to 2%, which is a very rare case. So that's why majority of the people have anterior dislocation followed by posterior dislocation followed by inferior dislocation, because I told you that for orthopedic doctors, the direction of dislocation is the final position of the head with respect to glenoid. This is one hell of an important topic of anatomy called rotator cuff, which I tried to cover along with its clinical application of types of shoulder dislocation. I hope you liked the video. I hope you understand the concept. Stay tuned for more. If you've liked it, please like it, share it, subscribe to the channel, share with your friends. God bless.